Pathogenesis of delirium. Acute myocardial infarct and sepsis. What do they have in common? What about malaria and hypoglycemia? Wernicke's encephalopathy and amitriptyline overdose? Hypertensive crisis and liver failure? All of them can cause delirium. The nature of delirium multi-etiology is unknown. The pathophysiology of delirium is also regarded as unknown, or at least insufficiently studied. However, is it really so complicated? Delirium is disturbance of consciousness. Material foundation of consciousness is bioelectrical interaction of neurons in the cerebral cortex. Therefore, any damage of this interaction will cause disturbance of consciousness, including delirium. To replace any damage with specific pathophysiological causes, let's remember that a resting neuron has negative charge on the inside surface of the membrane and positive charge on the outside surface. Resting membrane potential is maintained by sodium-potassium pump, which actively transports sodium ions out of the neuron. The active transport requires the input energy in the form of ATP. For ATP synthesis, the neuron requires glucose and oxygen. When the neuron is stimulated, voltage-gated sodium ion channel opens up and sodium ions rush into the cell because of the electrochemical gradient. The membrane becomes depolarized. Local depolarization of the membrane causes the adjacent sodium channel to open, and the process is repeated. As a result, the depolarized area, or a bioelectrical impulse, propagates down an axon. The arrival of the impulse at the presynaptic terminal starts the process of neurotransmitters release into the synaptic cleft. Those neurotransmitters bind to receptors of the postsynaptic terminal and open sodium ion channels. The postsynaptic neuron becomes activated and sends a signal to the next neuron. So, there are only two real causes of delirium: interruption of the signal propagation or interruption of the signal transmission. In the first case, it may be electrolyte abnormalities, ATP depletion, blockage of the sodium-potassium pumps, or ion channels. In the second case, it may be lack of the neurotransmitter synthesis. Neurotransmitters insufficiently release. Inactivation neurotransmitter into the synaptic cleft, or the postsynaptic receptors blockage. Now, it is possible to explain why delirium can be developed in so different disorders. Acute myocardial infarct. The cerebrum consumes 20% of cardiac output to maintain function. Acute myocardial infarct with low cardiac output affects cerebral blood flow. Inadequate blood supply leads to the lack of oxygen, therefore neurons lose their ability to create energy in the form of ATP through aerobic metabolism. As a result, the sodium-potassium pump stops working and electrochemical gradient disappears. So, neurons can't propagate signals along the axon. Functional failure of a large number of neurons reduces brain networks interaction. At the mental level, it is manifested by delirium. The development of delirium in case of any systemic hypertension can be explained the same way. Ischemia of the brain cortex occurs not only when the blood pressure level drops lower than the autoregulatory limit, but also when it is higher. Posterior reversible encephalopathy. The elevation of blood pressure level above the upper autoregulatory limit leads to vascular leakage and pathogenic edema. Because of fixed overall intracranial volume, cerebral edema causes intracranial hypertension, which results in mechanical compression of the blood vessels, decrease in cerebral blood flow, ischemia, and delirium. Acute liver failure causes hyperammonemia. In the brain, ammonia is detoxified to glutamine within astrocytes. Astrocytes are the most numerous cell type in the brain and occupy about 1/3 of the cortical volume. The increased synthesis and accumulation glutamine in astrocytes results in astrocyte swelling. It causes cytotoxic brain edema, ischemia, and delirium. Now, sepsis-associated delirium. Activated by inflammatory mediators, leukocytes dissociate tight junctions of endothelial cells in the brain vessels. That causes increased vascular permeability, edema formation, ischemia, and delirium. Sepsis is systemic inflammatory response syndrome caused by infection. There are many other reasons for SIRS, and all of them can cause delirium. Wernicke's encephalopathy. Thiamine is critical for the ATP synthesis, so thiamine deficiency can also cause delirium. Drug-induced delirium. Cardioglucosides, cocaine, and atropine can cause delirium because of blockage of sodium-potassium pumps, select ion channels, and postsynaptic receptors. Of course, all presented pathogenetical schemes are approximate. Of course, there are alternative theories that explain the development of these disorders. However, it is not so important whether the real mechanism of brain edema in hypertensive or hepatic encephalopathy is vasogenic or cytotoxic. It is important that all these disorders have common final pathway: lack of the brain network's interaction. The proposed concept is confirmed by EEG, which measures the overall electrical activity of the brain. If the number of normally functioning neurons decreases in delirium, the total electrical activity must be decreased too. Indeed, there is diffuse slowing on electroencephalogram in delirium. The degree of EEG slowing in delirium correlates with decline in performance on cognitive tests, and both EEG slowing and cognitive dysfunction normalize when metabolic derangements leading to delirium resolve. These final pathogenetical mechanisms take place in delirium of any etiology, not only in the cases described above. These mechanisms are the material basis of Bonhoeffer's exogenous type of reaction, first described about 100 years ago. For a better understanding of delirium nature, we have to answer one more question. Why do some patients develop delirium and others don't under the same clinical conditions? This diagram helps to answer the question. So, there is a healthy brain on the left, and the brain which has lost 30% neurons because of a disease on the right. Both reflect reality adequately. Now let's imagine that some acute exogenous harm turns off 30 billion neurons in each of them. In the first case, 70 billion neurons are able to create clear consciousness, and 40 billion neurons in the second case are not able to do it. So, organic damage of the brain is a fundamental predisposing factor for developing delirium. That's why even half a pill of amitriptyline, Today's constipation or a minor surgery can cause delirium in elderly patients. And more. There are differences between hyper and hypoactive delirium in this diagram. The proposed concept implies that the level of consciousness is directly proportionate to the number of normally functioning neurons and inversely proportionate to the neurotoxicity of exogenous harm. Therefore, delirium is acute brain failure, intermediate clinical state of the hypothetical spectrum, the extreme points of which are clear consciousness and coma.